Dr. Tamara Wexler is an endocrinologist specializing in neuroendocrinology and reproductive endocrinology, nationally recognized for her expertise in post-TBI pituitary dysfunction. She has served as an attending physician in internal medicine at the Massachusetts General Hospital and is the founding director of the NYU Langone Medical Center Pituitary Center. She is an elected member of the Endocrine Society Clinical Guidelines Committee and of the University of Pennsylvania Institute for Diabetes, Obesity, and Metabolism Leadership Council. Dr. Wexler will be chairing the session on post-TBI pituitary dysfunction at the Endocrine Society's 2021 annual meeting. She currently directs TBI pituitary research at the Rusk Rehab Center, as well as helping to establish similar registry and research programs at other institutions. Right now, she's establishing a telemedicine clinic, Neuroendocrine Associates, for patient care. As you can see, we have the right expert to share this with us. So thank you so much for being here, Dr. Wexler, and I'll let you take it away.
Thank you so much. I really very much appreciate that lovely introduction, and I'm thrilled to be able to share this with you today. It's a pleasure really to get to speak about this and to get to address a general audience on it. Let me first make sure that you can see my screen.
Yes.
Okay, great. So today what I'll be focusing on are some of the changes in pituitary hormones that can happen after a concussion or TBI. You'll notice I use those terms rather interchangeably because pituitary changes can happen after any severity of head injury or concussion. And really how those changes might impact patients and their families. My interest in this area started with a patient, such as the patient I describe here. There was a patient referred to me about 6 months after a cycling accident. He was a married father, had been an avid cyclist until the accident, and had worked for an investment bank until that time. And the reason I have a picture of Edvard Munch's The Scream here is that the way this patient and so many others like him have described what they were going through really reminded me of the inspiration behind the painting. Munch wrote about the painting, I sensed a scream passing through nature. And that really to me echoes what I hear from too many people about a disruption to their baseline. This particular patient described cognitive, emotional, and physical changes ever since his concussion. He had trouble processing information and thinking at the same speed. He used the term brain fog. He said, I'm just in this brain fog all the time. He didn't really enjoy things anymore. He felt very apathetic, and he specifically described feeling inadequate both as a provider and as a parent. He'd noticed a 20-pound weight gain over 6 months. He'd noticed this particularly because with his cycling, he was quite fit. And he'd had sexual symptoms, including a lack of libido and some erectile problems. Those had led him to a physician a few months earlier. He'd been given testosterone, which didn't help, and he'd stopped it before the time that he saw me. When he saw the provider before I met him 3 months after his accident, some labs had been drawn. I'm going to describe later what all of these labs mean, what the point of these hormones is. But just briefly to give you a taste of what this man was told, cortisol was drawn. That's the so-called stress hormone. It not only goes up in times of stress, but is important in supporting the body in times of stress. That level had been checked at 10 a.m. That's a little late to be checking it, and we'll talk about the importance of checking at the right time. It looked pretty normal at that time. A TSH, which is the thyroid stimulating hormone, and I'll talk about that soon too, which leads the thyroid to make hormone, looked normal, but it was drawn by itself, also not particularly informative here. His testosterone had looked low at first when it was drawn, but when it was drawn at the more appropriate time of 8 in the morning, it was normal. And his IGF-1, which is a measure of growth hormone, looked normal also. So with these relatively normal looking labs, is there any reason to think he might have a pituitary problem? And even if he did, should we think that might have anything to do with his symptoms? And that's what we're going to talk about. Symptoms can be pretty nonspecific. I mentioned that the patient said he was in a brain fog, and he had also said, I'm in a dark hole. I drew that when he said, I'm in a dark hole, I took that out of a letter he wrote me. And the full context is as follows. He wrote, right now I'm in a dark hole, and all the ropes that have been thrown down to me, none of them have helped me. I'm looking for another rope. And I think that this underscores both the distress and difficulty many patients experience, and also the importance and responsibility to be precise about what is known, to set expectations appropriately and to set the appropriate amount of potential hope, but not too much. So this is what I like to emphasize with anyone who would come see me in my office. One, we know that pituitary deficiencies occur at higher rates in patients who've had a concussion or brain injury. Two, all of their symptoms are not likely to be due just to the pituitary, but that said, it's straightforward to test for problems, and if a deficiency is diagnosed, to replace it. And to whatever extent pituitary dysfunction is responsible for those symptoms, that should be expected to be reversed. So I'm going to start out first by talking about what we know about pituitary dysfunction after traumatic brain injury. Then we'll talk about the pituitary itself, what all those hormones mean, why it matters, the implications for people after concussion, and with a practical approach, and plenty of time for questions. There's a lot of data on these screens. You do not have to even pay attention. I'll highlight what's important, but if that's something that you'd like to see, I include it here, and I'm always happy to share more at other times. Here's what we know. We know that pituitary deficiencies are seen at a higher rate in adults or children who've had a concussion than in the general population. According to the literature, chronic anterior pituitary deficiencies are seen in 15 to 60% of adults after a TBI. Let me explain the terminology here a little bit. Chronic refers to at least 3 months after injury. I use that term specifically because in the acute period, there can be changes, but for most of the hormones, it's thought to be adaptive. So we don't tend to look that. I'm happy to take questions about the acute period and the question and answer period, but for this talk, we're going to focus on at least 3 months after, and actually it's often quite a bit more than that after a concussion. Rates are also higher in children. It's important to know that these are from studies, and the studies aren't the general population. So they have a specific study group. So it's not that 60% of everybody with a concussion should be expected to have a problem, but whoever they studied. It might be people with specific symptoms or people in a specific rehab center, but regardless, it's significantly higher than the general population. There's been one study done of pituitary problems in a general population. It was done in a whole region in Northwest Spain, and less than 4 out of 10,000 people had any pituitary problems. So huge difference from that to, even the lower range of what we see in the literature of people after traumatic brain injury. The severity of the injury does not predict whether or not someone has a problem. It can happen after a mild concussion. It can happen after a severe brain injury. The most commonly affected hormones in the later period, especially as you get later on, look to be both either growth hormone or the sex hormones, and really growth hormone once you hit 1 year after traumatic brain injury. The specific percentage given in the studies depends on the test they use and the threshold. There's something else just to be aware of if you're looking at studies themselves, that while there are very clear guidelines as to what constitutes, for example, growth hormone deficiency, not all of the studies follow those guidelines. Someone can have a deficiency right after a concussion or years later, and they can get better over time or appear even distant from the event. So there are quite a number of studies in both children and adults that look at both 3 months after the injury and 12 months after the injury, and they follow the same people. And they find that some people have hormonal problems that get better, and then new problems can show up where they didn't exist before. All of which is to say that it's just important to keep thinking about and to even consider retesting. Different types of injury can lead to deficiencies. There have been studies of recurrent sports injuries. Most of those were first done in boxing or kickboxing, which is why I have a 1931 bronze here. There's a very nice study that was done by Kelly and his colleagues in 2014 of retired football players that used rigorous standards and found a higher percentage of people with growth hormone deficiency in those retired football players. And that was done in retired football players who self-reported concussions on but not off the field, and who self-reported poor quality of life. So that was the incoming group. They didn't have to have any other symptoms other than poor quality of life. There have been 2 studies of military blast injury and 1 newer study of non-blast military injury that also support that there are higher rates of concussion after any type of brain injury incurred during deployment. because so many people have had a concussion, you can talk to many people, and if you keep asking, you find it that someone has had a concussion in the past. There's a lot of interest in figuring out whom do you screen. It's not practical to test every single person, so how do you know whom to screen? Unfortunately, there's not a lot of good information about how you can predict it. I mentioned that injury severity does not help. Imaging doesn't help either. You can have a completely normal CT scan or MRI and have pituitary problems, or you can have problems on your MRI, but there's no one-to-one correlation. No biomarkers or anything you draw in your blood that's not actual lab values that we'll talk about is clinically relevant. And the best we have is symptoms. There was a really interesting study done by Cuesta and colleagues in 2016 that showed that symptoms of low sex hormones, so that was menstrual irregularities in women, or sexual side effects in men, erectile dysfunction, predicted not just low sex hormones, but also other types of pituitary problems, and at a pretty high rate. So you don't always know exactly what the problem is if you have those symptoms, but the symptoms themselves tell you something. And indeed, I do think that symptoms are the best predictor we have, or the best indication of whom to screen. If someone has consistent symptoms consistent with pituitary dysfunction in the months and years after a concussion, it's important to think about a full evaluation. So let's talk about what those symptoms are and why they matter. Symptoms can include changes to body composition, skin and hair. Pituitary changes themselves cause changes in bone structure and in the heart and other cardiovascular parameters. It can cause the mental fog I talked about, increased fatigue and decreased energy capacity and exercise capacity, changes to menstrual cycles, and mood changes. I talk about quality of life. There are actually specific tests for this, so, but generally patients are the best indication of feeling that something is different. We know that pituitary deficiencies impact health and quality of life, and that if they're left untreated, they're associated with increased mortality and morbidity. So it does matter. Now, you may have noticed that the symptoms from pituitary deficiencies and the symptoms you can see from post-concussive syndrome overlap quite significantly. Happily, though, there are tests to determine whether or not there's a pituitary component at least. So what is the pituitary? The pituitary is a gland that sits up behind the top of your nose. If you put one finger at the top of your nose and the other at your temples, where those fingers interact, that's where your pituitary gland sits. And it acts like a master regulator of a number of hormones. The hormones are all listed here. There's growth hormone, GH, which leads to the production of IGF-1. LH and FSH are the hormones that are made by the pituitary that are responsible for the production of estradiol, or for ovulation in women, or for the production of testosterone and sperm in men. TSH, or thyroid stimulating hormone, leads to the production of thyroid hormone from the thyroid gland, and ACTH leads to the production of cortisol, that stress hormone, from the adrenal glands. I list prolactin here under a dotted line because while all of these hormones are themselves stimulated by a signal from the hypothalamus, prolactin is tonically inhibited. There's always something keeping it suppressed, and so any interruption to that axis can lead to an elevation in prolactin. So it's more common to see an elevated prolactin level. I said that symptoms can be broad and non-specific, but there are certain symptoms that go along with each axis that might be useful to go over. ACTH deficiency or adrenal insufficiency can look like a mild fatigue that someone really wouldn't notice on a daily basis, or it can be pretty severe. It can lead to nausea and confusion, low blood pressure. People can feel like they were hit by a bus. The reason this one's important to think about, and this is the one hormone of those that I've listed important to think about in the acute period, is because while you may not need that much cortisol day to day, if you have a stressor, if you're in an accident, if you get very sick, you need to support your blood pressure. And if you don't have enough cortisol on, it could prompt a fatal crisis. It's easily replaced if it's diagnosed, but it's important to think about. And this is the one of all the hormones I mentioned that you might want to think about in the acute period. TSH deficiency leads to hypothyroidism, which looks like hypothyroidism from any other cause. Fatigue and weight gain, feeling cold all the time, changes to hair and skin, changes in a period. In children, this will look like altered school performance most frequently. LH and FSH deficiency in women can lead to changes to the menstrual cycle, fatigue, and mood changes. In men, the low testosterone caused by this leads not only to a decreased libido, and actually the most specific symptom for it is a loss of spontaneous morning erections, but also to more general symptoms such as depression, low blood cell count, changes to muscle mass or lower body hair. And in children, puberty will be delayed until replacement. For growth hormone deficiency, growth hormone is not only responsible for linear growth. That's how it often shows up in children as impaired height, impaired growth, or in younger children, an altered fat distribution. It's described as looking kind of like a cherub in younger children, but it is responsible for a host of other symptoms in adults. And the deficiency leads to this decreased quality of life, impaired executive function, so slowed thinking, trouble with memory, increased visceral fat or central fat, and again, the fatigue and reduced exercise capacity. I mentioned that prolactin can be decreased, it's usually increased actually, and the symptoms from an elevated prolactin are the same as from low testosterone or low estrogen because it suppresses that axis, and you can also have milk production in either men or women. So to summarize the symptoms, you can have physical symptoms, you can have cognitive symptoms, you can have emotional symptoms, and they can be nonspecific or they can sort of point in one direction, but it's really just through awareness of these presentations that you even think about an evaluation. And if on an evaluation a deficiency is identified, it's really important to think about replacing it. I always like talking about the feedback loops of the pituitary system. Feedback loops are what help keep your body in balance normally. So schematically, if this is your pituitary here, a signal is sent from the pituitary to another organ. I'm going to just switch to, here we go. Let's talk about one of the systems to make it easier to think about. Your pituitary is in your brain, your hypothalamus is as well, and the thyroid is at the base of your throat. So the pituitary sends this TSH, this thyroid stimulating hormone signal to the thyroid. The thyroid gland makes thyroid hormone. That thyroid hormone feeds back to the pituitary and the hypothalamus, which then recognize there's enough around and everything works well. It's a little bit like the temperature controlling in your house. So if there's not enough thyroid made, let's say that somebody has a problem with the thyroid gland themselves, and the thyroid gland itself isn't able to make enough thyroid hormone, the pituitary senses that and puts out more of this thyroid stimulating hormone. It increases the stimulatory signal. Frequently, TSH alone is what's checked, and if it's normal, everything's considered to be fine. That only works if you know that your pituitary is working correctly. If it's not, the pattern would be quite different. So the pituitary couldn't put out quite enough TSH. The thyroid gland can't make quite enough thyroid hormone, but the pituitary can't mount the appropriate response. It can get the TSH into the normal range, but not high the way you'd want to drive more thyroid hormone. So a normal TSH can be misleading here. That's why I say normal can be misleading. You need to look at TSH with the thyroid hormone, usually a free T4. And if a free T4 is low and the TSH is normal, that's actually abnormally normal. It's inappropriately normal. It should be elevated, and it tells you that the pituitary is not able to mount the correct response. So context is really important. I mentioned already that time of day is important, that those labs weren't drawn at the right time of day. That's because these hormones like thyroid hormone, testosterone, cortisol, go up and down over the course of a day. And if you're looking for a deficiency, you want to check it when it's supposed to be higher, so you know that you're not just catching a normal low in the cycle. That's in the morning for testosterone and cortisol around 8 a.m. That's in people with a normal day-night cycle, and that can be difficult, I recognize, especially after a concussion, but it's the best we have. So looking at 8 a.m. or earlier is important. And because of this, because the ups and downs, because there are ups and downs, you may not be getting the right time of day. For some hormones, a single snapshot that you get from a blood draw may not be enough. And it may be important to do what's called dynamic or provocative testing, where you try to stimulate the hormone to go higher and you see if the body can respond. I give some more specifics here about exactly how you'd evaluate different hormonal levels, but what's important is that there are medicines, herbs, and other remedies, so some of the GNC or over-the-counter supplements can impact hormonal levels and change the tests and even mask a true deficiency, so it's important to think about that. You can check morning cortisol, or you can give basically a synthetic version of this ACTH to see if cortisol goes up, and that's how you test the pituitary cortisol axis. You measure low free T4 with TSH to measure for the thyroid axis. In terms of the sex hormones, in men, you need to have a low morning testosterone with inappropriately normal LH and F, or LH-FSH. That's just as I mentioned, the pituitary is not mounting the response and symptoms, and that has to be done on 2 separate occasions to diagnose it, because the difficulty in knowing if you're really getting the right time of day. In women, if someone's having a regular period, a normal period, you don't need to test. That tells you either that the body is working, that this part of the system is working, or if somebody's on a contraceptive pill that's giving them that normal cycle, you wouldn't be able to test. But it is important to remember that with an abnormal period or absent period, it's important to think about a pituitary cause. And I'll come back to that later, because I think this sometimes gets missed in women, where it's assumed that someone's period is off for a different reason, or that they have gone into menopause and you're missing a pituitary diagnosis. For growth hormone, you can test that IGF-1 level I mentioned, but it's only diagnostic if all of these other lines are down, and you usually have to do that provocative testing I mentioned. And that gets a little bit tricky in that it's only recently that we know that IGF-1 is not a sufficient screening test. Until about 2015, it was thought that if someone's IGF-1 was normal, you could stop there. And only if it was low did you go on to really test for deficiency by doing this provocative or stimulatory test. We now have lots of evidence that that is not the case. And in fact, these studies have been done in populations of people with growth hormone deficiency from pituitary tumors, or in the TBI population. You can have a normal IGF-1 and fail a provocative test. And it's really difficult to figure out, therefore, unless you do that provocative test. There are a number of provocative tests that exist. One commonly used one is the glucagon stimulation test. It's pretty inexpensive. It causes your blood sugar to sort of gently go down, and low blood sugar stimulates growth hormone release in a functioning system, but it takes 3 hours. There is another, this is in adults. There are different ways you think about it in children, but in adults, there's an oral medication that was just launched 2 years ago exactly, called macrolin or masamorelin, and that takes only an hour and a half, but it's significantly more expensive, and it hasn't been tested in this population yet, in a population of people specifically thought to have growth hormone deficiency from concussion. So this area is a little bit more up for discussion and can take time to really think about and to diagnose. Once you have your evaluation done, if a hormone is deficient, it should be replaced, and unless there's some kind of contraindication, in which case maybe it wasn't wise to test in the first place, but replacement is important to think about because of the problems that can happen with unaddressed deficiencies. And replacement should proceed stepwise. I had shown this box earlier. This is the order in which deficiencies are thought to most commonly appear, although really you can see any pattern, but more importantly, it's the reverse order by which replacement has to occur. You have to start with cortisol. If you gave somebody a thyroid hormone replacement and you didn't know they had an adrenal insufficiency, you hadn't looked for it, you could prompt an adrenal crisis. Similarly, you can't even test for growth hormone deficiency, let alone replace it, unless you've already made sure that they are at the appropriate level of sex hormones. So just going stepwise in order is important. And as I mentioned, the symptoms that are due to those deficiencies should start to reverse. Because that tends not to be the entire problem, I always recommend work with a concussion specialist or team too, but it is an important piece of the puzzle. So what is this? How did this affect our patient, for example, the man I talked about before? He had a full pituitary evaluation 9 months after his injury. We did the cosentropin stimulation, where you give the recombinant pituitary hormone that stimulates cortisol, and he more than rose above the threshold of 18, so his axis is totally normal. His TSH, we already knew that was in the normal range, but it was normal with a normal free T4, so his thyroid axis is fine. Testosterone was fine, as was prolactin, and his IGF-1 level looked normal, but at this point, we already had some evidence that that wasn't sufficient. So we did the provocative testing and he failed it. So he has growth hormone deficiency. He has a normal BMI, and in patients with a normal BMI, this glucagon stimulation testing threshold is 3. And he was not able to mount that response over the full test. So he has growth hormone deficiency. Now, could that be responsible for any of his symptoms? Yes, growth hormone acts throughout the body. It is responsible for glucose homeostasis. It supports heart health. It is important for brain health. Symptoms described by patients with growth hormone deficiency specifically include mental fog and fatigue. Again, not only from growth hormone deficiency, but very striking that the patients I've had with growth hormone deficiency use those terms on their own. Quality of life effects, body composition. He had noticed a weight gain as well, and exercise capacity, as well as a host of other things. There are studies of patients who have growth hormone deficiency specifically after different types of traumatic brain injury. And just to summarize all of this data, the patients who have growth hormone deficiency are not as happy on quality of life metrics and do not do as well as those who have sufficient growth hormone. And there are specific studies also following patients who have shown difficulties with processing speeds, executive functioning, cognition, and quality of life after traumatic brain injury. And the replacement of the growth hormone does indeed help in those areas as well. There is not a good consensus on when you would test and replace growth hormone the way that is for the other hormones, where you wait about 3 months and then you can test and stepwise replace. Because of the evidence that growth hormone deficiency can resolve on its own up to 1 year. It's not studied after 1 year, but because of that, there are a lot of places that say, well, let's not test it until 1 year. And at that point, if you're low, we'll replace it. It's also reasonable to consider replacing it earlier and then retesting. You might recover and you can test for recovery. So that's been my practice, but it's both practices. Then you do have to do the retesting. So there's a range of practices because of the existing information and the way the studies were done. It's also really important to emphasize that, again, growth hormone replacement should only be considered and testing done after replacement of the other pituitary deficiencies. Otherwise, you're kind of wasting that long test. Practically speaking, I'm just going to keep an eye on the time. This goes over a few things that we don't know, but we've talked about those a lot already. One of the things we don't know is what causes the problem. There are 2 general schools of thought. One is that it's the injury itself, that the pituitary is particularly prone to kind of getting knocked around. And another is that there's a chronic inflammatory state set up afterwards, and that's why you can see, for example, growth hormone deficiency showing up even years later. We believe that the same criteria should be used to diagnose deficiencies as are set for other contexts as well, and the replacement should be initiated in the chronic period. And thus far, the same improvements are seen with replacement in patients who've had a traumatic brain injury as in any other patient with deficiencies for another reason. A lot of the variability is just because of the way the studies are designed. And practically speaking, this basically just says that if you have consistent symptoms that persist in the chronic phase after a concussion, consider pituitary evaluation. I list a number of the lab values that may be useful. It's really important to get it done precisely because there has been a lot of evolution in our understanding of how to evaluate pituitary hormones, and definitely to consider replacement in patients who have deficiencies, and to consider repeating evaluations, because if 6 months after an injury you don't have a deficiency but symptoms increase or show up or don't go away, it might be that later on there's a deficiency that's shown up. Few populations to discuss for special considerations. In children, there are higher recovery rates by 1 year. Symptoms will be different in children, and diagnostic testing is different in children. In women, it's important to think about this for menstrual irregularities, for delayed puberty, or for absence of periods. Again, the testing here helps us. In normal menopause, the ovaries have stopped making estradiol. The pituitary gets that signal and ramps the FSH way up. If there's a pituitary problem, that FSH will be inappropriately normal. If it's normal and estrogen is low, that's a pituitary problem, and it should increase the suspicion for other pituitary problems. I think that this is an area that gets missed at times. So to summarize, this is an important area to think about after traumatic brain injury because you can replace it here, and it can really also, I think, help with other recovery along the way. If not addressed, pituitary deficiencies will continue to impact health and quality of life. It definitely is a challenge to know whom to screen. We do not have a good predictor, so at the moment we just go by symptoms. Knowing that tests may show that it's not from a pituitary problem or that it may be a pituitary problem, but that again, if it is, you can replace that. I welcome any other questions.
Thank you. That was tremendous. A lot of information there. I can see from all the questions it's been very helpful. So as we're scrolling through the questions that you've left, if you have other ones, please send them. We're gonna start going through some questions we've already received. Victoria wanted to ask, does damage to the pituitary gland cause weight changes? So I guess you've covered that, but do you wanna add some more color to it?
Sure, it certainly can, absolutely. That some of the hormones, if they're impacted and deficient, can alter your body's ability to shed fat and to gain muscle, both of those. There are obviously other things that can predispose towards weight gain that are due to a concussion as well, but it's certainly worth considering this because if it's a component, you can replace and address it.
Okay. Mary asks, are any symptoms specific to older adults? So I think we've got a lot of folks who are older, and I think this is of concern to them.
That's a great question. While I see adolescents and adults, I'm trained as an adult physician, and that's the majority of the patients I see, and everything I said pertains very much to older adults. The area that can get a little bit tricky when you're not dealing with deficiency is ranges of normal come up. What should a normal testosterone be? What should a normal growth hormone be? And I think it's one of the reasons it can be a little bit tricky to get replacement, because there's separately an industry where people are given growth hormone even if they aren't deficient to sort of promote muscle gain, et cetera. However, if you are actually deficient and you've had a traumatic brain injury, you absolutely qualify to be legally prescribed and covered for growth hormone replacement. I don't know that that is the question, but I would say that everything I mentioned is very true for older adults. I think that fatigue and exercise capacity are really important. Some of the other areas involving heart health that wouldn't normally be evaluated in younger adults are already being evaluated, and things may even show up there that could be due to, for example, growth hormone changes. Okay.
For women, we had a question, would any of these hormone disruptions affect pregnancy, including will it affect the baby's health?
Okay, so that's a great question. So the question is then if somebody's already pregnant, not about the ability to get pregnant?
Well, I think, might as well answer both if there are answers to both.
Yeah, so if it changes to the hormonal axes like the thyroid axis or the sex hormone axis will impact the ability to get pregnant. But again, if those hormones are replaced, you fix it. The one thing I should mention here is in men, if they have a testosterone deficiency and they're thinking about fertility in the next year, thinking about having a baby in the next year, you don't give back testosterone, you actually give back things that mimic the pituitary hormone, so that you don't cut off the ability to make sperm. You can absolutely give replacement. It's a different replacement in men who are thinking about becoming pregnant over the next year. If they want to get pregnant in the future, you can give testosterone and then switch over later. It doesn't permanently alter anything. So that's an important comment about fertility in men. And in women, similarly, you wouldn't give estrogen to somebody who was deficient and looking to become pregnant. You would give the pituitary hormones. In terms of once somebody is already pregnant, to the extent that the health of the mother is being affected, that can affect the health of the baby, as with any other way in which the health of the mother is affected, whoever is carrying the baby. But I don't know of any way that these deficiencies specifically will affect the unborn embryo, the fetus. Usually the body puts a lot of systems in place to protect an unborn baby. So it's really the health of the mother that tends to be the focus there. But I'm happy there's not research done here. Research is not done on pregnant women in general at all.
Right.
But this is what we know about how these hormones work in women when they're pregnant. In general, it's harder to get pregnant, but once you're pregnant, there aren't studies, but it is more of a concern just to support normal supplement in the normal replacement, I should say, excuse me, in the mom. There are different thyroid needs during pregnancy, but they're well described what those are, and it's easy to follow. So during pregnancy, the thyroid hormone labs should look different. That's the one area that's quite different.
Okay. And we talked about this before we started, but how do you find an endocrinologist or the right doctor who understands concussion and this issue? Because as you know, and we've talked about, most people struggle to find somebody when this might be an issue. So first, let's talk about the work you're doing to sort of help build a registry, and then how you could be contacted for in-person or telehealth consultation.
Sure. Yeah, absolutely. So we have been running a registry out of NYU just to follow patients to sort of describe what happens. The interesting thing here, and in fact, part of the frustration, is that all of what I'm describing is standard of care and has been known for a long time. There is a list in adults of a finite number of potential etiologies for growth hormone deficiency for which you're allowed to prescribe growth hormone replacement. TBI has always been on that list, top of the list during, when I was in my training, and yet really a lot of attention has not been paid to it. So not all endocrinologists are necessarily aware of this. And it can be hard to find someone, and it is a real frustration that it can be difficult for patients to feel heard, and difficult to find places where testing can be appropriately done. That's what we were just talking about, that, if you just do a single blood draw, any lab can really do that, but these provocative tests are a little bit more complicated and hard to find a place where you can really sit and do that. And those of us who specifically study this area are trying actively to sort of find a network. I spend a lot of time trying to find physicians and kind of interviewing physicians near people who reach out to try and get them somewhere local. And because of that, I'm actually trying to now start a clinic where at least I could speak with patients in a number of states and offer telemedicine capabilities, because they can't find someone closer to them. And it's really hard. It's really frustrating. But there is active work being done to try and both establish that network and to raise awareness among not just endocrinologists, rehab medicine physicians. A lot of them are aware of this, and neurologists. The first patient who was referred to me was referred to by the chair of the NYU Rehab Medicine, and set up a whole nice collaboration. And it's really at the same time that it's frustrating being hard to find people, it's really rewarding how interested a lot of the fields are about this. I think we just need to get information out.
Yeah, and for everyone watching, if you do want to find a referral for this, feel free to use our helpline, and we'll work with Dr. Wexler to find people. This is a specific question, so maybe not a long answer if there isn't one, but can being on prednisone long-term affect these tests?
Yes, absolutely it can. Prednisone is essentially acts in for cortisol. So prednisone is the glucocorticoid, is the cortisol replacement. You can, with your doctors watching over you carefully, and if you check first, they may ask you to stop it, to test that axis, to retest it. If someone's on prednisone treatment for a different reason and on higher doses of prednisone, many syndromes require prednisone treatment, it absolutely does that. It will itself suppress your adrenal axis, and you will need to keep taking it and to double it if you're sick, for example. That's stress dosing is what it's called. And it can also affect the other axes if at higher doses. It's known that can happen.
Thank you. How about with the endocrine system and PCS causing an inability to regulate body temperature? Have you seen that? Have you seen people complaining of like hot flashes in teenagers?
It's interesting. There's different ways there's different types, different situations in which I've heard this. One, we know that changes to thyroid hormone change someone's sensation of temperature. Thyroid is sort of a metabolic regulator in a sense. So if it's too low, people feel cold. If it's too high, they'll feel hot. Changes to sex hormones cause hot flashes. And that can happen at any age if it is a sudden change. There also are anecdotal descriptions, not published, but anecdotal descriptions of changes to some of the posterior pituitary hormones that I didn't talk about causing changes, but this is from a colleague of mine who has seen this. It's not published or described. So yes, a lot of things can lead to hot flashes, cold intolerance, different things. Pituitary hormonal alterations are some of those causes, but not all of them.
All right, I'm going to try to give you a specific challenge from Jenny. My 15-year-old, try to telediagnose this in 5 sentences. My 15-year-old son suffers from ongoing intense headaches and fatigue with brain fog 2.5 years post-concussion. Endocrinologist suggested he may have resistance to thyroid hormone. The alpha subunit marker came back normal. However, so this doctor thinks it's unlikely the pituitary is the problem and suggested prescribing thyroid hormone to see if it helps symptoms. Do you think this is a worthwhile course of action, and or is further investigation of the pituitary warranted in this situation?
Yeah, so I will, yes, further and full investigation is warranted in this situation. One, because you'd want to see the full thyroid evaluation to know why it was resistance that was thought about. I actually am really interested in seeing that full thyroid panel, but also other things can cause that. Has growth hormone been looked at? Now, before you look at growth hormone, you want to check the adrenal, the cortisol. You want to do the TSH with free T4 together, looking at them. You want to check the sex hormones. Now that changes a little bit depending on the stage of puberty an adolescent would be at, and very much growth hormone deficiency can also create what you're describing. I would strongly, it's always hard. You don't want to undermine another physician. I don't know the conversations there, and I never want to touch that relationship. With the information you gave me, I would want a full evaluation first, because you don't want to give thyroid hormone without that full evaluation. You don't want to give it if there's something else missing where you could be much more precise. I think that's what happened in the patient that I described. They were given testosterone. Everything wasn't checked. They weren't testosterone deficient. It didn't help. He was growth hormone deficient, even though the symptoms looked the same.
Yeah, that's interesting. So how about some operational questions? At what point do you start asking for a neuroendocrine assessment after concussion?
Not earlier than 3 months. And there's no point after that you wouldn't want to. If it's been 6 years, great, look at 6 years. There was actually a case study where they found someone who, it looked like the diagnosis was made at 6 years. It was a 19-year-old with growth hormone deficiency, I think. It looks like it showed up 6 years later, but maybe they just didn't look earlier. So years later is not a problem. You just really don't want to look too early. And for growth hormone evaluation, probably not before 6 months, but in part that's because you have to evaluate everything else first. That's one where it seems to take a little longer to recover. In the early period, it's almost as though the body can want to kind of hibernate and fix itself. This is a very high level, not scientific description of it, but so some of those other changes, let's say testosterone's low. It is in many people right after a traumatic brain injury, but that's maybe the body just trying to reserve its strength for other things. It doesn't mean that it's bad. It may be adaptive, it may be important. So we don't look until 3 months and a little bit later for growth hormone.
Okay. And then for a logistics question, so primary care doctors can order these labs, or do you have to see a specialist?
Primary care doctors can begin the evaluation. The important part is knowing who's going to follow up, because if you're testing the cortisol axis, if you're doing a morning cortisol and it's quite low, or if you usually court stims are not done in a primary care office, but if they do it, if someone fails it, that's an immediate follow-up. But the rest is important and urgent, but not immediate. It's not dangerous to wait longer other than that adrenal axis. I have often spoken to another physician and said, my recommendation is to do this as a morning testing screen on a single blood draw, and I can take it from there, right? If everything's normal, then you're done except for possibly provocative testing for growth hormone. If something isn't, you might have to repeat it, but it's helpful to have those labs. So absolutely they can start the evaluation. Any physician who's aware of this can do it. You just want to make sure that that someone is aware of this literature.
Okay, and then when we talk about that follow-up, an endocrinologist or a neuroendocrinologist is obviously going to be your goal or qualified. And are there other specialties people could assume that person, if they have an interest, may be up to speed and able to treat this?
Yeah, rehabilitation medicine is one of those that there's been a lot of interest there. I mean, this is primarily a patient population that they see, so particular interest from a lot of rehabilitation medicine physiatrists who are looking for other ways to help their patients in concert with their other work. I prefer to also, I recommend to patients that they also have, again, that concussion team or somebody kind of acting like the quarterback, a medicine doctor, a neurologist, someone who knows them well, because there's going to be a lot of information coming in. This is also the last time, that you'd want to be dealing with all that different information coming in, sorting it out. But I find that that all of those specialties can be really, really helpful. And what matters is somebody that's aware of this and is your advocate. Right.
Well, thank you. And we'll take a few more questions. I'll read a few more questions off, and we'll try to wrap up by 5 for everybody. April asked, what can you recommend for someone who's on birth control?
In terms of the evaluation, since you don't.
That's the question, but you can imagine it probably hits from a lot of different angles, right?
So in terms of the evaluation, you can do the rest of the evaluation. You can't evaluate the gonadal axis, but that said, if it were low, that's one way you can replace it. So you're essentially being replaced with, depends on the type of birth control. If you're talking about an oral estradiol or estrogen-containing contraceptive, you're already getting the replacement, if it's that type of a contraceptive. And so while you can't evaluate while you're on it, that doesn't mean you have to go off of it because you're essentially already being treated. It may later become relevant if somebody decides they want to get pregnant and stops taking it and things don't reestablish themselves. That's the time period in which to look. And absolutely, there are always replacements you can give in people seeking fertility. It's just not the same ones.
Okay. And if you prescribe replacement hormones, do you have to stay on them for life?
Excellent question. In this situation, not necessarily. First of all, you don't have to do anything. The only one that's really essential for life is the adrenal replacement, which is the least common out of all of the ones I mentioned. Most common is growth hormone, next common is sex hormone, and then a scattering of people do have central hypothyroidism and even fewer the adrenal insufficiency over population. But people recover. So I like to repeat testing. You don't want to keep someone on something when their body can take over by itself. And you also want to be, all of these hormones can be monitored with the level. So you'll get blood draws. Every single pituitary hormone or pituitary regulated hormone is a little bit like, I call them the Goldilocks hormones, because too little is bad, but too much is bad also. You want just the exact right amount. And so you monitor that. You don't want to over replace someone ever. You want them to be at what you think their normal is. And if they're, so the answer is no, you're not necessarily on it for life at all. And that's why repeat testing is useful.
Great answer. So here's an interesting one. This person said the primary complaint of the patient you described, some doctors might diagnose as depression. And so this person might go to a psychiatrist. So when should a psychiatrist be suspicious or refer for a neuroendocrine evaluation?
That is a great question, and I am deeply chagrined I did not mention psychiatry as part of the host of different physicians that can be helpful here and can recognize things. It was an oversight on my part, because certainly patients are referred to me by psychiatrists all the time. And again, I think the big difference is here is in awareness. If the psychiatrist isn't aware of it, you can bring it to a psychiatrist. And by the way, I had a brain injury a while ago. I know that there can be hormonal changes over time, that these can also contribute to depression. Is that something I can look into? Doesn't mean it's the only reason for it. And I know that I keep re-emphasizing that because I just don't want this to be seen as a panacea, but oh my goodness, it's helpful to replace people who are actually deficient. That replacement, I had one parent say to me, it was like getting her son back. It really can make a dramatic difference in concert with other treatments as well.
Yeah. Could exercise intolerance or dysautonomia be related to pituitary?
Okay, that is a great question. There is not necessarily a link for exercise intolerance. Yes, dysautonomia is often a separate issue. It doesn't mean that there aren't also pituitary problems, and the thing that causes the dysautonomia can cause the pituitary deficiency, et cetera. But so that is not usually how pituitary deficiencies show up.
Okay.
Yeah.
And then I want to be respectful of your time here. So there's a lot of questions around the specifics of testing and questions to ask. So I'm going to ask you, do you have a one-pager? Be willing to create a one-pager for us for people to say, this is the conversation you should have with your doctor?
Yeah, so I'm going to send something over to you guys later this week to send out to everybody. And this is good for me to know that what I'll include is here's a basic screening testing panel you might want to do. So I'll make sure that's on it.
Wonderful. Okay. Well, thank you for taking this firing squad of questions. You did a wonderful job answering them all very concisely. So I think we will let you get back to your treating of patients. Let's give a big round of applause and thank yous in the chat for Dr. Wexler to show our appreciation. We love whenever you guys say thank yous. We always cut and paste them and send them over to the good doctors who do these webinars. So Dr. Wexler, this was fantastic. I learned a lot, our team learned a lot, and certainly hundreds of folks watching learned a lot. So thank you so much for your commitment to the patients and for putting together this webinar for us.
Thank you. It's really a pleasure. I appreciate the opportunity.
All right. So thank you again, Dr. Wexler, and thank you guys for joining, and thank you to the CLF team for making this come off very well and prepared, and getting me prepared. And if we weren't able to answer your question today, you're looking for help, we'll mention it every time, reach out to the CLF helpline. We want to help you solve your problems. There is help out there for you, even if you, and I think it was important to mention, a lot of questions were asked, and Dr. Wexler mentioned this, but it doesn't matter how many years you are from your brain injury. If this is your problem, you can still get tested and it can still be fixed. If you found this webinar helpful and you want to pay it forward, we welcome donations of any amount to help us continue to put these on. You can find a donate link in the chat, and I appreciate everyone who every week commits a little something to CLF. And then I'll just say thank you guys for joining us. It's been a great series. We've had great experts. Please let us know what you thought of today's webinar in the poll that we're launching right now. And then don't forget to sign up for the PCS newsletter to stay up to date on all of our resources and upcoming webinars. Take care of yourself, and best wishes on your journey to recovery. Take care.